Hello and welcome to the Processes and Documentation in the Pediatrics module. The first section of Processes and Documentation which you will need to learn is the admission clerking. This will be one of the core tasks required from you. Having good documentation skills and clerkship skills are going to be an advantage throughout your training. So let's take a look at how admissions work. Generally, as we understand, the pediatrics division is largely divided into general pediatrics and neonatal intensive care unit. Patients with pediatrics divisions are admitted either from the emergency department and the outpatient pediatric clinic or even from the labor room. So once the patient is reviewed and admission plans are ordered by the attending pediatrics team, which includes you as the house officer, the medical officer and the specialist, nurses from the emergency department, clinic or other wards will arrange a bed by liaising with the ward nurses. Once the bed is ready in the ward, the patient will be sent up to the ward. Admission docket will contain the patient's admission slip, payment receipt, and clerking documents done by the doctor attending in the clinic or emergency department. For the neonatal ICU or NICU, infants will be admitted directly to the NICU post-delivery. On arrival to the bed, the nurse in charge will ensure the patient is safely transferred to the bed in the ward and will take the vital parameters to be recorded in the observation chart. The nurse will also inform you that the patient has arrived and ready to be clerked or attended to. So what's your role as the ward house officer? As the house officer, you play quite an important role in clerking patients' history, performing physical examinations, ordering investigations including lab works and imaging studies. Basically, you will need to ensure all orders are carried out accordingly as well. Should you face any hiccups in performing them, always remember to seek help from your senior colleagues or from your team members who are your medical officers and your specialists. So admission clerking, as the name suggests, is carried out for patients who are admitted to the pediatrics ward. The house officer in charge of the new patient who's being admitted is expected to review the patient within 30 minutes from the time of admission. Review the clerking which was done earlier in the clinic or emergency department and have an idea of the case you might be dealing with to be able to revisit the history and fill up any more information left. Usually, in the pediatrics ward or the NICU, patients will be admitted with their mom or dad, depending on their age group. And for the infants who are admitted to the NICU, usually the history and the events that actually transpired prior to the admission can be recorded from the previous documentation that has been done. So what is done at the ED instead? From the emergency department, usually a medical officer would receive a referral call from the ED medical officer. Sometimes you may be in charge of ED referrals for that day, or you may be chosen to see the patient first. Therefore, you will need to do a detailed clerking and perform necessary physical exams prior to your MO's arrival. In cases where the medical officers are available, they would just go along with you to review the patient. So once chest x-rays or investigations are reviewed, patients will be admitted to the ward if necessary or else discharged with a TCA or to come again appointment. When the patient is discharged from the ED, please remember to order the necessary medications that has been prescribed by your medical officer or specialist. The cases that you might be encountering in the ED would be acute gastroenteritis, acute exacerbation of asthma, febrile seizures, to name a few. How about patients from the clinic? The patients from the clinic may or may not be transferred to the wards, but a full clerking will be needed as soon as you review the patient. Any plans, investigations or orders to be carried out needs to be done by yourself. Here, you will come across many follow-up patients including bronchial asthma, nephrotic syndrome, autism, cerebral palsy, and many more. Now let's take a look at the NICU, which is the Neonatal Intensive Care Unit. It is an intensive care unit specializing in the care of ill or premature newborn infants. Neonatal refers to the first 28 days of life. When you are posted to this section of the pediatrics department, you would need to go through the history from the mother's antenatal as well as the process during the delivery had taken place in order to know and follow up on the progress of the neonates. You will be receiving cases like neonatal jaundice, premature neonates, hypoglycemia, and a few more. So when you're done with your clerking and physical exams, you will need to present your case to the medical officer or pediatrician who comes to review. Write or type out every point and plans given by the medical officer or specialist. Do not take risk by just trying to remember verbal orders. Always remember to make notes, and whenever possible, get your medical officer or pediatrician to review what you have written or typed just to reconfirm. Once the patient is seen with your MO or specialist, always write their respective names on your clerking, such as seen with Dr. A, discussed with Dr. B, and attended with Dr. C and Dr. E. Now let's move on to case presentation. So a case presentation is a formal communication between healthcare professionals regarding a patient's clinical information. It is the job of the presenter to share the pertinent facts of a patient's case with the other members of the medical care team and establish a clear diagnosis and treatment plan. So in your housemanship training, you will be delivering many case presentations as your communication with your superiors begin here. You'll be evaluated from the point of history of presenting illness, examination techniques, findings, clinical judgment, and a reasonable plan. Just like other departments, pediatric and neonatal clerking starts with the general clerking as well. Here, we will be showing you how you'll be presenting cases to your superiors for referrals or even end of posting exams. We will be also showing you a few examples of case presentations for your better understanding. Let's begin with the opener. So you should begin every oral presentation with a brief one-liner that contains the patient's name, age, relevant past medical history, and chief complaint. Remember that the chief complaint is the reason that the patient sought medical care in his or her own words when they are able to, or otherwise it will be from their parents or caretaker. Moving on to history of presenting illness, elaborate on why the patient sought medical care. Describe the events that preceded the patient's presentation in chronological order. When it comes to past medical history, this should include the following information, which are the patient's medical conditions and medications consumed, any past surgeries the patient has had and when they were performed, and history of allergies that would be important to find out as well. Moving on to family history, this is any relevant conditions that run in the patient's family with an emphasis on first-degree relatives. Here, maybe you'd like to know if there was any history of family asthma or seizures that would be important pertaining to the clinical presentation of the patient. Next would be social history. So this section should include information about the patient's living conditions, parents' age and occupations, siblings, and their details would be pretty much needed. Moving on with physical exams. So once you have finished reporting the patient's history, you should transition into physical exams. You should begin with reporting the patient's vital signs. Next, you should discuss the findings of your physical exam. At the minimum, this should include your general impressions of the patient, including whether he or she appears sick or not. The results of your systemic review, which includes your respiratory, cardiac, abdomen, as well as your neurological findings if it's relevant. Next would be the results of your lab testing, imagings, and other diagnostics if they have been done. And finally, you should conclude your presentation with the assessment and the plan. Now let's take a look at a few examples. So in these slides before, we have discussed the general case presentation technique, and now I'm going to show you a few types of common case presentations in pediatrics and neonatology. So this scenario is about a child who was referred from the emergency department for acute exacerbation of asthma. This patient is 5 years old, male with underlying bronchial asthma on metered dose inhaler salbutamol under clinic kesihatan follow-up. So he presents with a complaint of having fever, cough, runny nose, and rapid breathing for the past 3 days. So the fever started 2 days ago, associated with chills. The mother claims highest documented temperature at home was 38.2 degrees. And he developed a cough and runny nose for 3 days now after sick contact with his elder brother. The cough was chesty in nature, hence the mother brought the child to the nearest general practitioner 2 days ago, and the child is currently on syrup amoxicillin on the second day. The child started wheezing and had rapid breathing this evening, therefore, she brought the child to the emergency department. Otherwise, oral appetite is good, there's no vomiting or diarrhea. As for past medical or surgical history, the patient has got underlying bronchial asthma on metered dose inhaler salbutamol with a regular follow-up. His last visit to the GP was 1 month ago, where he had required nebulization twice. As for social and family history, the child lives with his father and mother. The father is asthmatic and the younger sibling also has eczema. They have a cat at home as well as carpet usage at home. Now, when we come to systemic review, where we discuss on the general findings as well as the systems involved, we notice that the child is alert with full GCS, pink, not pale, has mild tachypnea, tachycardic, with a capillary refill time of less than 2 seconds, warm peripheries with good pulse volume, and it's got a weight of 25 kilograms and a height of 110 centimeters. The throat is injected, the tonsils are however not enlarged. And the cardiovascular examination was normal. However, for the respiratory system, there was an end expiratory rhonchi with prolonged expiratory phase heard on auscultation. The abdomen was soft, non-tender, and there were no obvious masses palpable. As for the lab investigations, we noticed that it's generally normal. However, the white cell count is slightly on the higher range of the normal range. The renal and liver functions were within normal values as well. The radiographic findings of the chest X-ray suggest there's evidence of some perihilar haziness. However, there's nothing very significant about anything else within the X-ray findings. So once you have presented your case, you can then end it with a plan given by your medical officer or specialist who has reviewed the patient before. Now let's take a look at case 2. This is an example of a neonatology case. So this is baby of Sandra, day 5 of life, delivered at term at 38 weeks via emergency lower segment cesarean section for poor progress with an ABGA score of 9 out of 10, birth weight of 2.8 kilograms with a current weight of 2.85 kilograms and normal G6PD. So the history of presenting illness involves baby being brought in by the mother for jaundice since day 3 of life, with the total serum bilirubin was being monitored at the clinic Kesihatan and was referred here today because the serum bilirubin was above the phototherapy level. The child has been on exclusive breastfeeding on demand, denies any pale colored stool, no concentrated urine. However, the mother claims the child is active on handling. The mother is 29 years old, para 2, antenatally did not have any issues. The high vaginal swab was negative for GBS. Maternal blood group is O positive, and the infectious screening is normal. Here you can actually mention regarding the parents' data, including their age, occupation, or if they've got any underlying medical problems as well. Now let's look at the examination findings. So the neonatal physical exam would be different from the pediatric or other departments as well. So you'll always begin with the anthropometry, which is the weight, the length, respiratory system, whether it is clear on auscultation with good air entry, cardiovascular system to look out for murmurs, abdomen, whether it's soft or distended, the genitalia being normal or not, whether the testis is descended well in males, the mouth, whether there's presence of cleft lip or palate, if there's any discharge seen in the eyes, whether the external meatus of the ears are present, if the spine is normal, and to look out for any evidence of spina bifida, signs of skin tuft or skin tag, and finally the neurological exam, which looks at the reflexes, which are the Moro's reflex, sucking, and the grasp reflex. Now there'll also be lab investigations that would be done for a patient who comes in this way, and you want to mention the laboratory findings as well as the capillary glucose findings and the total serum bilirubin, whether it is within or whether it's out of the phototherapy level. So once you have presented your case, you can then end it with a plan given by your medical officer or the specialist, and in most cases of neonatal jaundice would be phototherapy and follow up on the total serum bilirubin blood screening. Now let's move on to progress reviews. So all patients will require a progress review. This means you will need to review patients according to whom you're assigned to. The reviews may be twice or thrice a day, and you'd be assigned to beds or cubicles accordingly. Your work usually starts at 7 a.m., but it would definitely be better if you could come in earlier to review your patients prior to the morning rounds. You will need to know the progress and the current issues of these patients from the day before till the morning you see them. So do speak to the patients and their parents and ask them how they feel today. Also, not to forget to examine them thoroughly because you don't want to miss any significant changes that has occurred over the days. There are some tips to speed up your understanding of the case before you begin your review. Always ask yourself, why is the patient still in the ward? How many days is the patient in so far? If there's any surgeries done before, how many days post-surgery is it? And how is the wound doing? If it's just pertaining a medical problem, then you want to ask, what are the tests and treatment that the patient has received so far? And finally, what are the impending test results for today as well as the future plans or advanced plans for the patient? Reviews are done usually 3 times a day by the house officer in charge unless there's an emergency sets in. The AM review is done between 7 a.m. to 9 a.m. The PM review is done between 2 p.m. to 4 p.m. And the on-call review is done between 8 p.m. to 12 a.m. So once you have done with your reviews, present your review findings to your medical officer who will be doing his or her part of the review as well. There might be changes or additions to your review. Always remember to be at all times reachable, as you know your specialists or your pediatricians may have a really busy schedule. So sometimes they would just suddenly appear in for rounds. So you want to probably be around for your patient. Document promptly so that the nurses will be able to carry out their part of the plan as well. Next, let's move on to handovers. So a handover occurs when a house officer hands over the responsibility of care of a patient to another house officer, for example, at the end of his or her shift. So on average, handovers occur 3 times a day for each patient. Handover occurs at every level of care, from the consultants, the pediatricians, and even amongst nurses once their shift ends. So handovers are very important to ensure a smooth transition, as you will find much less disruption to team workflows and productivity rates. As a house officer, you'll need to know a well-devised format of handover to ensure pertinent information regarding the patient is not missed and to avoid any wrong information passed over. So these will include past events, which means details of what has been done for the patient as well as the patient's progress for the day or before. The present plans and events, which includes details of plans that have not been carried out, blood investigations or formal reporting from radiographic imaging if there are any, and future events would be details of upcoming plans given by the specialist or medical officer, as well as important or urgent events to look out for on patients' conditions. When service from another department is required, a request or order is made. Now, house officers are assigned to make requests following the plans in the daily reviews. So, how does a request work? Firstly, identify what is the test that is to be requested. Identify the departments involved. Then identify the officer in charge of taking the request from the receiving department. Outline the purpose of the request, urgency for the test to be done, how the test will be able to aid the diagnosis and management of the patient, identify the criteria needed for the requested test, and finally, identify the documents that are required to be filled. So to place a request or an order, the steps to follow include completing the request form for the test, calling or meeting the officer in charge of receiving the request, and once granted, informing the nurse on the plan to transport the patient over to the location of the test or to collect specimens for the test requested. And finally, documenting the trail as to who granted the test, when the test is planned for, preparations for the steps for the patient. If your request is not granted, take down the pointers to why it was rejected and convey the information to your medical officer. Your medical officer will then be responsible to troubleshoot the situation. Now, this chart shows us the examples of verbal requests and the tests that do not need verbal requests. So, examples of tests that require verbal requests would be reporting for radiographs, any early or urgent ultrasounds, CT scans, MRIs, group safe and hold or group cross-match coding, urgent full blood picture, and also an echocardiogram. And for those that do not need a verbal request, this would be basic routine blood tests, radiographs, as well as non-controlled medications. Now let's look at referrals. We'll see how referrals work. So referrals are made to other departments for their management input or suggestions, or if their skill sets are required in the management of a patient. First of all, identify the purpose of the referral. Then follow it by identifying the departments involved. Then to identify the officer in charge of accepting that referral from the receiving department. Then ringing up the officer in charge. And finally, documenting the trail as to the time at which referral was being made, the indication, and the medical officer who accepted the referral. If your referral is not accepted, take down the pointers to why it was rejected and convey the information to your medical officer. Your medical officer will be responsible to troubleshoot the situation. Now let's take a look at an example of a referral made from the pediatric department to the orthopedics department. So always begin your referral by speaking or communicating confidently and clearly. You can start off by introducing yourself by saying, "Good morning, Dr. Charles. I'm Dr. Betty, house officer from the pediatric department." Then you can follow on with stating the patient's details as well as the reason for the referral. So I'd like to refer a case to rule out compartment syndrome. This is a 6-year-old kid who is currently admitted to our unit for acute gastroenteritis. He had difficult intravenous line insertion, however, we managed to get through one last night. Overnight, his intravenous line tissued and caused a severe swelling on his hand up to the wrist joint. So on examination today, we noticed there is a large swelling as well as tenderness over the left wrist, which has limited range of movement and we're unable to feel the radial pulse. So when you're presenting a case, always remember you need to have updates of all relevant investigations prior to ringing up the officer in charge so that you'd be ready to answer their questions regarding the patient. Also, importantly, inform the reason or diagnosis of admission to the pediatric ward. For example, is currently admitted under PEDS for acute gastroenteritis. You would not need to present the whole initial plaquing regarding the pediatrics-related conditions unless you're asked about it. And then finally, don't forget to thank the team on their input as well as their review on the patient's matter. Now, finally, let's take a look at discharge. So a discharge summary plays a crucial role in keeping patients safe after leaving a hospital. So hospital discharge summaries serve as the primary documents communicating a patient's care plan to the post-hospital care team. House officers are responsible for formulating a complete discharge summary and carrying out discharge work as stipulated in the summary. So there are 6 main components on a discharge summary. The first is the reason for hospitalization. This is then followed by significant findings, any procedures and treatment provided throughout their stay, the patient's discharge condition, the patient and family instructions as appropriate, and finally, the attending physician's signature. And now, what you need to do prior to allowing your patients back home? So you need to make sure that patient's general condition is well and all plans given by the specialists or the medical officers are carried out. Remember to order discharge medications early so patients will receive them on time. This ensures a smoother process flow. These processes are in keeping with the lean healthcare system adopted by the hospitals to minimize wastage and maximize productivity. Should there be a need for a medical certificate for school to be issued, inform your medical officer or specialist in charge to fill in the certificate before the patient leaves, as it will be included in their discharge docket. If the patient has been co-managed with other specialties, communicate the discharge plan with them. This will be necessary to ensure there are no clashing plans or appointments. The patients who require a follow-up of care at the outpatient clinic needs to be briefed about their action plan. For example, asthma charting, asthma plan education needs to be given to the patient prior to discharge. And as for the neonates, they need to be seen and evaluated overall, and the mother's well-being or social status would need to be assessed as well, because some patients may require medical social welfare referral. Well, we have come to the end of this session. Thank you for your time.